Cek. 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 11.30 cek. Cek, cek, cek. 11.31 sore cek. 11.31 cek. Cek.
Mulai dari kita agak membangun dulu. Nggak ada lensnya. Makanya antara semua data nanti kan. Kemarin mobil udah dulu ya. Apa? Salah. MC ngasih moderator. Kasus kedua cek.
Cek 1 2. Cek. Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom. Namo Buddhaya. Greetings of welfare. Peace be upon us all. Ladies and gentlemen, welcome to today's guest lecture, Advancing Pediatric Anesthesia, Opioid-Free Techniques and Regional Blocks for Hypospadia Surgery. It is an honor for me to stand before you today as we gather to celebrate this momentous scientific event. First and foremost, let us express our praises and gratitude to the presence of Ida Sang Hyang Widiwasa, the Almighty God, for it is by His grace that we gather here for today's guest lecture. First of all, let me introduce myself. I am Serlin, and I will be guiding the proceedings of this joyful event. Before we commence, I would like to extend our greetings to our esteemed teachers and the invited guests who have joined us in this moment. Today, we are going to hear in-depth discussion from our guest lecturer, our visiting expert, Dr. Luc Pielens, who has traveled all the way from the Netherlands to share his expertise with us today. Welcome to Bali, Dr. Luc. We hope you enjoy your time here in Bali, and please join me in giving a heartfelt round of applause for welcoming Dr. Luc. Before we proceed to the main lecture, allow me to extend our sincere gratitude and appreciation to PT Fresenius Kabi for their unwavering support for today's scientific event. As many of us are aware, PT Fresenius Kabi is a global healthcare company consistently providing health quality and evidence-based life-saving medicines and technologies for critically and chronically ill patients to enhance patient care and clinical outcomes. With that, it is my pleasure to invite the representatives from PT Fresenius Kabi to share a brief presentation that are highly relevant to our clinical practice. To Fresenius Kabi team, the time and place is yours.
Baik, terima kasih atas kesempatannya. Kali ini saya mohon izin untuk bahasa Indonesia saja ya, karena target saya adalah para dokter-dokter yang ada di tempat saya. Mungkin kalau di guest kita hari ini mungkin di tempat beliau sudah ada juga, udah tahu juga mungkin ya. Jadi targetnya kita ke dokter-dokter yang ada di depan saya saja ya. Jadi perkenalkan dulu, saya Desa Pipit dari PT Fresenius Kabi Indonesia. Jadi kali ini saya datang dengan atasan saya yang ada di belakang, namanya Pak Bayu. Dan izinkan saya kali ini untuk menjelaskan mengenai produk-produk dan Fresenius Kabi itu siapa sih, gitu ya. Jadi kali ini saya akan membawakan sedikit mengenai parenteral nutrisi produk portofolio dari PT Fresenius Kabi. Sebelumnya sudah dijelaskan PT Fresenius Kabi itu siapa. Jadi PT Fresenius Kabi itu merupakan perusahaan kesehatan global yang dimana kita berfokus kepada nutrisi klinis, infus dan transfusi. Jadi kami menyediakan produk dan jasa yang didedikasikan untuk menolong pasien kronis dan kritis. Perkenalkan, ini adalah produk-produk parenteral nutrisi kami. Ada Smooth Kabiven, ada Smooth Lipid, mana dalam Smooth Lipid ini sudah ada 4 kebaikan jenis lipid, dan kita juga punya aminosteril, dan dipeptipen, ada nephrosteril juga, yang dimana di dalamnya itu mengandung amino acid, dan ada juga kita punya mikronutrien untuk memenuhi kebutuhan nutrisi harian, itu ada solufit, ada vitalipid, dan glikopos. Untuk Smooth Kabiven-nya ini sendiri mungkin sudah tidak asing lagi di telinga dokter-dokter sekalian ya. Jadi kita sudah merupakan pioner dari 3CB. Kita punya 2 sediaan. Kita ada sentral dan perifer. Nah, untuk yang akses perifer itu kita dibagi lagi menjadi 2 jenis sediaan, ada yang 1206 mili dan 1448 mili. Nah, untuk kebutuhannya di anestesi mungkin kira-kira yang sentral ya, Dok ya. Untuk kita di sini kita punya yang akses sentral dengan volume kecil tapi kalorinya tinggi. Dan Smooth Kabiven kita ini sudah dalam all in one bag itu sudah mengandung glukosa, lipid, dan asam aminonya. Dan juga kita dalam lipidnya kita itu sudah mengandung 4 jenis kebaikan lipid, di mana di Smooth Kabiven kita itu sudah mengandung soybean oil, ada MCT-nya, ada olive oil-nya, dan juga ada fish oil-nya. Dan di dalam bag Smooth Kabiven juga sudah mengandung asam amino yang mengandung taurin. Ini sekilas untuk bag size-nya, jenis-jenisnya, dan total kalori dan isi-isinya. Jadi kita tadi sudah dijelaskan bahwa ada tiga jenis, 2 sediaan, perifer dan sentral. Jadi yang perifer itu kita bagi menjadi 2, yang kalori 800 dan kalori 1000. Jadi untuk yang sentral kita hanya punya 1493. Untuk osmolaritasnya kita sendiri itu yang sentral itu 1500 dan yang perifer kita 800. Ini contoh dari contoh bag dari Smooth Kabiven sentral dan perifer. Yang ini yang menjadi perbedaan di antara perifer dan sentral itu ada di asam amino dan glukosanya. Kalau yang perifer itu glukosanya ada di paling besar, kalau misalnya yang sentral itu glukosanya ada di kalau misalnya sentral itu asam amino. Yang ini ada Smooth Kabiven perifer, kalorinya 1448. Yang sama seperti tadi, di dalam all in one bag kita itu sudah mengandung ada smooth lipidnya, asam amino, dan glukosanya. Seperti yang sudah dijelaskan tadi, smooth lipid yang ada di Smooth Kabiven kita itu ada 4 jenis lipid ini, dan di mana masing-masing itu punya fungsinya tersendiri. Ada fish oil-nya itu yang merupakan sumber omega 3-nya, dan soybean oil-nya itu untuk memenuhi asam lemak esensialnya, untuk olive oil-nya itu untuk sumber asam lemak purba, dan MCT-nya itu sumber energi cepat. Selain itu kita juga Smooth Kabiven kita diperkaya dengan vitamin E dan untuk menetralkan peroksidasi dan stres oksidatif. Kenapa kita menjelaskan dari tadi lipid? Karena ada beberapa penelitian yang mengatakan bahwa lipid itu keseimbangan lipid yang ada di Smooth lipid kita itu mampu dan terbukti untuk memperbaiki liver enzim, TG dan segala macam, dan selain itu juga bisa memperbaiki respon imun dan sebagai anti-inflamasi juga, memberikan dampak positif pada fungsi dan integritas sel hati, dan mengendalikan kadar TG. Selain itu juga tadi sempat dijelaskan bahwa dalam Smooth Kabiven itu sudah mengandung asam amino yang mengandung taurin. Nah, di dalam Smooth Kabiven ini merupakan satu-satunya kesediaan resipi yang mengandung taurin taurin, di mana taurin itu dapat menekan kolestasis pada pasien pasca operasi dan memiliki efek dan sebagai nutrisi esensial untuk pasien kritis pasca operasi dan pasien dengan trauma atau sepsis dan yang menjalani radiasi atau untuk memenuhi kebutuhan tinggi akan asam aminonya ini. Dalam sediaan sentral sudah mengandung asam amino 50 gram per liter di sediaan sentral ya, dan di perifer itu sudah mengandung 32 gram. Selain itu juga smokabipen mengandung zinc, di mana pasien TPN yang mendapatkan tinggi protein lagi, yang mendapatkan parenteral nutrisi tinggi itu, ya rentan mengalami kekurangan zinc. Jadi di dalam smokabipen itu sudah mengandung zinc yang mampu menyembuhkan luka dan mampu membantu dalam penyembuhan luka dan memperbaikan jaringan sintesis protein, terus respon imun dan kapasitas oksidatif antioksidatif. Selain itu, smokabipen juga bisa diberikan untuk pasien di atas 12 tahun dan sudah di-approve juga untuk penggunaan jangka panjang. Selain itu juga untuk memenuhi kebutuhan pasien ICU mungkin ya, untuk dokter-dokter di pasien ICU biasanya dipakai. Dan untuk pemberian pada pasien di atas 12 tahun itu sudah ada penelitiannya, seperti yang ada di sini ya, sudah ada penelitiannya bahwa ini tuh smokabipen bisa digunakan dalam jangka panjang dan baik bisa digunakan untuk pasien di atas 12. Nah, ini sedikit rekomendasi dosis untuk smokabipennya. Jadi untuk dosisnya sendiri itu untuk dewasa 13 sampai 31 mg berat badan per hari. Kalau yang ini kan karena contohnya sentral, jadi dia infusnya secara sentral. Dan untuk laju infusnya itu sendiri itu ada di sana, dan untuk pemberian infusnya ini dapat dilakukan dalam waktu yang cepat, misalnya 3,5 jam untuk pasien dengan berat badan 70 gram. Nah, untuk smokabipen periferal, kita untuk laju infusnya itu tidak melebihi dari 3 ml per kilogram berat badan per jam atau 1 tetes per kilogram berat badan per menit. Jadi lamanya infusan itu yang direkomendasikan sebenarnya adalah 14 sampai 24 jam. Tetapi sebenarnya smokabipen kita itu stabil dalam waktu 36 jam. 36 jam setelah pencampuran. Tapi dari kami sendiri, dari presidensi kami sendiri menyarankan untuk dihabiskan dalam waktu 24 jam itu sudah smokabipen sudah stabil. Kenapa dalam 24 jam? Karena smokabipen kita itu sudah disesuaikan dengan si pasien. Ini adalah contoh dari penelitian meta analisis yang menunjukkan manfaat klinis dari parenteral nutrisi yang dipakai oleh asam lemak omega 3. Jadi dalam penelitian ini menjelaskan bahwa asam lemak omega 3 itu mampu menurunkan lama rawat inap secara signifikan selama 2 hari, menurunkan lama rawat di ICU secara signifikan selama 2 hari, dan menurunkan risiko infeksi secara signifikan hingga 40%, menurunkan risiko sepsis secara signifikan sebanyak 56%. Ini penelitian cost effectiveness yang menunjukkan bahwa adanya beberapa penghematan biaya setelah penggunaan PN yang dipakai fish oil dibandingkan PN yang standar. PN yang terkait dengan fish oil itu mampu lebih cost efektif dibandingkan dengan penggunaan PN yang standar. Jadi key takeaway-nya itu smokabipen merupakan nutrisi parenteral, nutrisi terbaik, tinggi protein dan energi. Jadi komposisi makronutrien yang seimbang, mengandung asam amino dengan jumlah Selain itu juga mengandung smoke lipid di dalamnya, dan sediaan smoke capipen versus minyak zaitun atau kedelai dan emulsi minyak kedelai memberikan manfaat sebagai fungsi dan integritas sel hati pada pasien bedah, respon imun dan inflamasi yang baik juga pada pasien bedah dewasa pasca operasi, dan mengurangi masa rawat inap di rumah sakit untuk pasien pasien pasca operasi. Dan selain itu juga smoke capipen mengandung zinc yang bantu mempercepat perawatan luka, penyembuhan luka. Nah, selain itu juga selain smoke capipen yang mungkin jarang terdengar oleh dokter-dokter sekalian, itu kita punya originator dari glutamin, kita punya di capipen. Jadi untuk komposisi dari dipeptifen kita ini adalah larutan infus konsentrat 20% L-alanil glutamin, dan mungkin ini belum ada di sini, cuman kita sebagai originator juga di glutamin ini juga membantu untuk mempersingkat masa rawat inap pasien. Pasien-pasien rawat inap biasanya dipakai, kalau yang tadi itu kan biasanya smoke capipen dipakainya di ICU. Mungkin ini nanti bisa menjadi choice untuk dokter-dokter yang membutuhkan glutamin, kita punya dipeptifen itu originatornya. Mengapa harus originator? Jadi glutamin itu Jadi kenapa harus originator? Karena glutamin itu tidak stabil secara kimia dalam larutan. Jadi glutamin itu juga memiliki tingkat pelarutan yang tinggi. Dan dalam sterilisasi dengan panas dan saat proses penyimpanan, glutamin dapat terdegradasi dalam bentuk dalam membentuk asam piroglutamat dan amonia yang bersifat toksik. Jadi selain itu glutamin itu glutamin itu terbentuk dalam saat sterilisasi dengan panas maupun saat proses penyimpanan. Selain itu juga terhidrolisis secara cepat dan lengkap setelah pemberian intravena selama 3-5 menit. Tolerabilitas baik, aman dan efektif, solubilitasnya tinggi di dalam air, dan komponen yang cocok untuk melengkapi larutan asam mati. Selain itu juga kita punya multivitamin. Selain dipeptifen juga kita mempunyai multivitamin, yaitu solufit dan vitalipid. Untuk solufit kita vitamin kita itu adalah vitamin larut air, dan vitalipid itu kita vitamin larut lemak. Untuk vitamin kita yang vitamin C dan vitamin B itu terdapat dalam produk kita, yaitu vitamin solufit. Kita mengandung vitamin C dan vitamin B kompleks, sedangkan untuk vitamin larut lemak kita itu mengandung vitamin A, D, E. Untuk pencampuran solufit dan atau vitalipid N itu satu vial untuk vitalipid bisa ditambahkan ke dalam larutan minimal 100 ml sampai 500 ml di mixing. Jadi kalau dokternya mau di mix vitalipid dan solufit, itu nanti bisa di mix dulu vitalipidnya ke dalam solufit, nanti dilarutkan ke dalam infus seperti itu. Jika mau dipakai solufit aja, nanti tinggal dilarutkan larutan minimal yang ini minimal 100 sampai 500. Untuk solufit itu bisa dilarutkan dalam 10 ml water for injection, glucose, dan sodium chloride. Jadi solufit yang sudah dilarutkan juga bisa ditambahkan ke dalam glucose dan sodium. Ini sedikit gambaran mengenai pencampuran dari solufit dan Selain parenteral nutrisi, kita juga memiliki enteral nutrisi portofolio. Kita punya fresh subin ya. Jadi untuk fresh subinnya ini representatif, medical representatifnya itu ada di belakang. Bisa dihubungi Mas Fajar yang ada di belakang sana. Jadi kita punya beberapa produk enteral nutrisi. Salah satunya adalah yang terkenal adalah mungkin kemarin di acara anestesi kemarin itu ada fresh active. Ini kita punya fresh active yang whey protein. Kita punya kaleng dan kita yang punya saset. Oke, kemarin dibagi ini yang protein yang saset. Itu satu saset mengandung 10 gram protein. Dan itu ya, kita kemarin ada sempat bagi-bagi presubin powder. Presubin powder rasa vanilla. Itu juga merupakan enteral nutrisi dari kami. Selain itu juga kita juga punya karbohidrat loading. Itu ada kita presubin juicy. Cuman ya mungkin dokter belum terlalu kenal dengan presubin juicy kami ya. Mungkin saya kontak-kontak siapa yang mau nyoba presubin juicy. Kami punya karbo loading presubin juicy. Selain juicy kita juga punya supportan presubin renal dan presubin Nah ini dia fresh active. Ini juga fresh active yang tadi saya bicarakan. Dari kandungannya itu 2,6 gram BCAA per 10 gram proteinnya itu kita 98,8% whey protein isolate dan di mana whey protein isolate itu merupakan salah satu jenis whey protein dengan kemurnian yang paling tinggi. Jadi kalau misalnya dokternya butuh yang kaleng, jadi bisa satu sajinya itu sama dengan 2 scoop fresh active. Jadi kita sudah 0 laktos dan 0 serat. Whey protein isolate. Untuk rasa produk kita ini tidak ada rasa dan bau. Istilahnya netral. Kalau misalnya mau dicampur makanan dan minuman apa aja, itu bisa, asalkan untuk makanan yang panas itu jangan terlalu panas. Itu yang hangat karena isinya protein. Jadi kalau misalnya nanti proteinnya masuk ke panas kan jadi hancur gitu. Jadi ini bisa dicampurkan ke makanan. Mungkin perbandingannya sama putih sama telur kali ya. Jadi kalau misalnya satu saset fresh active itu sama dengan dia 4 butir telur ya beli Fajar ya, sama dengan 4 butir telur. 2 butir telur berarti 2 butir telur. Jadi satu scoopnya fresh active sama dengan satu butir telur. Oke, terima kasih. Sekian yang dapat saya sampaikan. Terima kasih banyak. Mungkin ada pertanyaan. Mungkin. Jika tidak mengenai parenteral nutrisi, mungkin enteral nutrisinya mungkin bisa ditanyakan. Mungkin ada yang berkeinginan untuk melakukan penelitian mengenai carbo loading mungkin, atau efektivitas protein mungkin apa. Oke, karena waktu juga sudah habis, dokter. Jika ada pertanyaan, mungkin nanti bisa dihubungi Bapak kita dan ada pertanyaan kita. Pertanyaan akan kita tampung dulu. Nanti izinkan kami untuk kontak dokter dengan pertanyaannya. Sekian yang dapat saya sampaikan. Terima kasih banyak.
Thank you to the team from PT Fresenius Kabi for the presentation. We will now proceed to the highlight of today's program, and our main scientific sessions today will feature 2 highly relevant topics in pediatric anesthesia. The first lecture will discuss about opioid-free anesthesia in pediatric surgery, and the second topic will explore caudal or dorsal panel block for Hypospadia's correction. All sessions will be moderated by our respected teacher, Dr. Putu Herdita Sudiantara, Specialist Anesthesiology and Intensive Therapy. Without any further ado, I would like to hand over the session to our moderator, Dr. Herdita.
Thank you, Dr. Serlin. Good afternoon, everyone. Two. First, okay, today we will discuss the topic about pediatric anesthesia. We have two topics today. The first is the opioid-free anesthesia in pediatric. So we will look the safety, maybe the multimodal anesthesia, and then we have a regional block for Hypospadia surgery. So maybe my privilege to introduce our speaker, Dr. Luke from the Netherlands, and an expert in pediatric anesthesia and regional technique. We extensive experience in opioid-free strategies and urogenital pediatric surgery. Okay, Dr. Luke, the floor is yours. See ya.
She said that I was coming here all the way from the Netherlands, but that's not really the truth. I was in Indonesia. Sindri, stop. So I'm from Nijmegen. This is my city. It's a small city. Very huge tertiary hospital. That's hospital I'm working in. It's a university hospital. Special. Kids. I'm a pediatric anesthesiologist, so I work with the kids in my hospital. And in my hospital we are. Is this doing better? Oh, much better, I think. Yeah, now it's working. Huh? Now it's on. So I'm working with kids day in, day out, and who's working with kids here? Is doctor there? Doctor there. Kids are a bit different. We think they are more challenging. The more you work with them, the more you get used to it. It's less challenging if you work more. But in the beginning, might be challenging. But you get it. It's nice to work with kids. It's fun. I laugh with them. But okay. Kids, pediatric surgery, and we want to have it opioid free. Why do we want that? Why do we want opioid free? Sizes. Which one is going up? Which one goes up and down? Got it. Got it. Why opioid free? Are opioids not good? What do you think? Opioids are to kill the pain in your patient. So opioids should be good. So opioids should be something to help you to give your patient pain-free surgery. And important, because in surgery it's under anesthesia, but postoperatively, a pain-free period postoperatively is what your patient wants. But your job is to provide it. But how are we doing that? The problem is that patients are start to abuse our medicines. And is that patient's part or doctor's part? Are we the one that made it possible for them to abuse? Is it because we use opioids and they like it, and then they want to have it again and again and again? And then it becomes a problem. From the US, 2017, they wrote that opioid abuse in children, an emerging public health crisis in the US. An emerging public health crisis means more and more and more kids seems to be abused with opioids. Among pediatric surgery, persistent opioid use after surgery is a concern among adolescents and young adults and may represent an important pathway to prescription opioid misuse. So maybe it is us, doctors, giving the possibility to our patients to be pain-free by giving them a prescription again and again to use the opioids postoperatively. Postoperatively, that means, why do we need as anesthesia being opioid-free intraoperatively? We'll come to this. We'll go along with this. The rise and tide of opioid use and abuse, the role of the anesthesiologist. Should we be aware of it? Should we work on it? Is it us starting the abuse? And if we think a bit like this, then maybe we should definitely think about, maybe we should go into an idea of opioid-free anesthesia. That's why we should think about it. How can we do that? We'll talk about today multimodal analgesia. And the key tool for that is my hobby, regional anesthesia. If you go to the dentist, Dr. Gigi, I know that because next week I will do a lot of Gigi. I'm going to do Subing Bibir operations with maxillofacial surgeons from my hospital in Lombok. And they are the Gigi doctors. If you go to the Gigi doctor, they have to pull out one of your teeth or do something with your teeth. Do you inject yourself with morphine to be pain-free? You don't do that. You put the doctor a local anesthetic. So you don't feel the pain for a couple of hours. What do you do then? After the couple of hours, it starts to be a bit painful again. You use some paracetamol and maybe an NSAID or something like that. Or do you start to use opioids? No. So common sense in these kind of things is using the most important tool with anesthesia and the basics, pain relief. Okay. So, if we think about opioid-free anesthesia, it started with the introduction of opioids. Far back in history, when I was young, resident, a little bit more further away, it started to be mostly gas induction with the mask, Make it deeper, deeper, deeper. Let the surgeon operate, and then take the mask away and let wake up the patient. Kind of monotherapy. Then we realized maybe we should use more pain killings, because when the mask is away and the patient wakes up, there is no pain killing. The patient has a pain. So we need to use some pain killers. So then they introduced opioids. And with the induction of opioids, we start to have a balanced anesthesia. You know what it is, balanced anesthesia? Balancing. My God, how can I balance here? Balanced anesthesia is the start to have the pillars in anesthesia. There are 3 big pillars in anesthesia. One is sleep, one is pain, one is relaxation. 3 pillars. Meaning, don't use the sleep, things like that. Started with ether. Don't use the sleep in total to put the patient this far asleep that they can operate. Use the sleep only to let them sleep. And use some opioids, kill the pain. And then maybe need some relaxants to maybe intubate the patient or give the surgery a little bit more help to open the wound, abdominal area, thoracic area, things like that. So there was a start of balanced anesthesia. We started to use more and more opioids. They provide a very, very strong pain-killing action without too much hemodynamic differences. Very strong analgesia. And it starts to become, in those years, like around the 70s, it starts to become more and more the basis of general anesthesia. When I was a resident, it definitely was the basics of general anesthesia. Opioid based. Now, 30 years later, we are trying to change it back. Are we changing it back to a monotherapy? We are changing it back to a multi. So for mono, we became like 3 pillars. Now, every pillar is not just one medicine we are going to use. It's multimodal medication. That's what we are doing. If you talk about the pain pillar, then we talk about the analgesic ladder. What do you use if you've been to the dentist? It starts with, first step, just paracetamol and NSAIDs. Postoperatively, if the patient can do just with paracetamol and NSAIDs, it would be fine. If you know that this surgery will have more pain postoperatively and will have more pain for the next few days, you need something extra. It's about this extra because then it starts to have mild opioids. And if it's even more severe pain, it goes up to the opioids. There's the ladder. The more patient might have postoperative pain, the more we, anesthesia, will prescribe this for the postoperative pain relief. Meaning, yes, we definitely start to give the patient morphine, to give the patient opioid. And from that moment, the patient might start to abuse it. So our job, more or less, worldwide, and definitely coming out of the United States, because the problem there is much bigger, it's not that big problem in my country. Thank God. But it is definitely in the United States. So they want to avoid you to go definitely up to step 3, but maybe also not up to step 1. So we need to think about a different way of having your patients more pain-free post-operatively. Yeah? Okay. Okay. So, what do we do in anesthesia? The anesthesia analgesic ladder was opioid based. And we give a lot of opioids, and then maybe a little bit of acetaminophen, ketamine. Maybe we use a bit of regional anesthesia, and then on the top some new medication that might even give some extra pain-free for your patient. We started to give opioids. Make sure your patient doesn't feel anything. And they liked it. Because opioids is not only killing the pain, but it's giving you also a good feeling. You should try it. I don't know. Right? So this was anesthesia. Opioid-based general anesthesia, multimodal general anesthesia. We are going to use different forms of pain relief. And actually, we should go more from this old way, opioid-based, where there is already a little bit multimodal general anesthesia. As you can see, it's opioids, some other medications, some other things, dexmedetomidine, lidocaine. It starts to become more multimodal analgesia. So from the monotherapy to the balanced anesthesia, having 3 pillars, within every pillar, there is more and more multi-modal ways of using medication. And especially in this pain pillar, we are going to the multimodal analgesia, and that will change the pyramid. The pyramid will become different. There is no base of opioids anymore. Because if we start with a base of opioids, we give the patient the possibility to like that. But if we can avoid that, and we give them another base that is also good for post-operatively, we can avoid to give them the idea of, oh, I like this opioids, I want to use that more and more, even 2 weeks after surgery. In this ladder, we are going to look at these medications. What are we doing there? What is in there? Acetaminophen NSAIDs. That's the first step of the World Health Organization's pain ladder. Should be in the base. You give all your kids paracetamol, diclofenac or something like that, start after the induction. After the induction, every kid gets paracetamol, diclofenac. You choose for diclofenac, you choose for something else. Diclofenac is for the kid. That's the base. Only the paracetamol is synergic with morphine. So 1 and 1 is not 2, but 1 and 1 is 3. So the more you use your paracetamol and have it already in the system of the patient, you can use already less morphine because of the synergies of these 2 medications. Important to understand, important to know. Your patient should have paracetamol inside before you even start to give morphine or opioid. Because you can give less with the same effect. Same efficiency. Then there is regional anesthesia. That's my topic. I'm talking about that subject a lot around the world, not only in Indonesia. Regional anesthesia. We've been talking in the car a bit about regional anesthesia. A lot of people think it's really challenging to teach these blocks kids. It's challenging to put them asleep and give the block, or awake and give the block. We'll come to that a bit later again. But I think you should use, every patient on your table deserves, sorry, do I need to speak in here better? I'm not good at, but okay, I speak like this, more too close to my mouth. Every kid on your table, every patient on your table deserves actually the local regional anesthesia technique. You go to the DG doctor, you ask for local anesthetic because you know you're going to give me pain. What's the best painkiller? The best painkiller is regional anesthesia. Problem is, it's not lasting for days, only for hours. But at least, who is going to the DD doctor and said, no, I don't need that regional anesthesia. No, you just take my tooth, or you just do something with my tooth, and me, the pain no matter. Not me. I go to the DD doctor and took my paracetamol and diclofenac. And for sure, I asked the doctor, give me that regional anesthesia. I deserve it. You're going to do me pain, you're going to give me pain. I want to have it blocked before it's entering me. But your patients on the table might deserve the same thing. Think about it. Right? So if we look at the new way, regional anesthesia, I think it's really the keystone nowadays. It was in this article too. The keystone to take away pain from your patient is a good regional anesthesia technique. So you have to teach a lot about all different kind of block that you can do, but that cost me a few days, and that I don't have. Maaf, yeah? But we will talk a bit about it. Then there is this. And this is a mixture of medication that you might use or not use, but by using one or all four, we are start to talk about the multimodal analgesia. So some of my colleagues, they like to give everything a little bit. They give magnesium, they give lidocaine, they give dexmedetomidine, maybe one shot of ketamine, maybe a pump of ketamine during the duration of the operation. What do? Do you mix these things? Do you just use one? Or maybe two? But realize yourself that the moment you're using one of these drugs, you already are performing multimodal analgesia. Definitely when in the base you already use these three things: paracetamol, NSAIDs, and a local regional anesthesia technique. If you have used the base, doesn't mean, oh, then I don't need to use this anymore. No, you still use that multimodal mixture of a different kind of medications, because it's the mixture itself that already helps patients to become pain-free. Let's go through these medications, what I said. Let's see what is this multimodal analgesia. What is in there? Gabapentin. Do you have that here? Pregabalin. You have it, you use it. You use it postoperatively or preoperatively. Depends a bit here and there. In orthopedics, adult orthopedics in my hospital, all patients give pre-medication of these medications. So they're already prepared for the pain, a little. Let's see what it is. Gabapentin, if you put on your PubMed and you look for gabapentin or pregabalin, you will see this amount of results of articles that are showing you that this medication is really helping you with postoperative pain. So this medication we might use or should use instead of waiting postoperatively and giving opioids, because this can help. There are some ifs. It gives a reduce of opioid use, but it also it is a multimodal pain management regime, so it really can help. But it is even the recommendation. There is a guidance recommendation in the US, guidelines in the management of postoperative pain. There is a lot of things. The American Pain Society, the American Society of Regional Anesthesia and Pain Medicine, and the American Society of Anesthesiologists. I think this is everything to do about anesthesia in the United States. Every society who thinks is important in anesthesia is mixed up in these guidelines. And in these guidelines, the recommendation 17, so there is a list from 1 till 17 at least, and even more, I can tell you if you read the article, that it says you should use this. There is a recommendation to use this. So you might try to think about it. Maybe definitely in these operations that have a lot of postoperative pain, we might start to do the same as in my hospital and use this as a pre-medication already. Just think about it. Put someone on it. Good. But there are some things that I consider, like this dipyromate and phenytoin, they give some cognition negative effects, meaning kids might not have a problem with finding the words, so the cognitive function of the kid might be reduced. But these two medicines we are not talking about. We are talking about gabapentin and pregabalin. And there was too little information to reach conclusions about the effect. Does that mean so we don't have to think about it and we just can give all our kids this medication? I'm not surely convinced, but I'm definitely convinced to use it in adults already. And for kids, we might still be a bit slowly, wait a little bit, see what's going to happen in literature, see what new investigations might learn us in the future before starting to give it in all our kids, just due to this. Although it says there is no effect. On the other hand, it gives patients that are using it, especially kids, to gain weight. And to gain weight might be giving other comorbidity in these kids. So that's also something we might not really want in our kids. So for adults, definitely yes. For kids, these medications maybe are in the waiting room. We need more knowledge about this for children. Lidocaine, do you use that? Yes, for the blocks. No, I mean IV. Do we use it IV? There is a local anesthetic effect, of course. There is antithrombotic effect. There is an anti-inflammation effect. And a central anti-hyperalgetic effect. So it has advantages. And so we use it. We put it on a pump. Do you give it one shot or do it on the pump? One shot? Yeah. We have it on a pump, low dose. Just make sure it's going in. And it's helping in the total of multimodal analgesia. If you put this in PubMed, you can't find anything. You find over 1 million, which you can't divide between IV and local regional. I tried it, but still in the IV there are a lot of locals. And in the IV, there is not that much that you can divide into postoperatively or something else. So it's difficult to understand how many numbers are exactly for this particular thing. Use it IV and see what's happening postoperatively. Strange, but it's kind of difficult. Magnesium. If you put magnesium for postoperative pain, you see 310 results. I made this lecture, sorry, not yesterday. So maybe now the numbers are already a bit more because the lecture is a few years back, 2 years or something. So there might be more numbers, but even 2 years back, it was already this amount of numbers of articles showing magnesium. And then it's sad It gives a reduction in both pain and morphine use. That's what we wanted. Make sure we don't need to use opioids postoperatively. So it can help. Dexamethasone. Do you use it? Antiemetic. Also, when you do a regional anesthesia technique to prolong the duration of your local regional anesthesia, it helps. So even if you have done the first basic little step, paracetamol, NSAIDs, regional anesthesia technique, dexamethasone can help you. Can help the patient to be pain-free, awake from surgery. 850 results. Now, in literature, I think it's over 1,000, because a lot of things are publicated around this medication. And we are now using it standard in every patient, because it definitely is a big path in the multimodal anesthesia. And we see here reduced positive pain and opioid consumption. This is the major key. This is where we are looking for. This is why we want it. Ketamine. You use ketamine. Lots of results. Even out of older days, we already know it. Even from the ICU, if they are on different kind of medications and still not comfortable, they might use ketamine on the pump. You do that here? Sometimes. Yeah. But then realize that maybe the ketamine is not in the pillar of the pain, but ketamine is in the pillar of the sleep. Relaxation. Sedation. Because there is some discomfort in the patient. Ketamine can be used for both pillars a little bit. If you use it for the pain, for sure it will work. For sure it will work. As it said, it's effective in reducing morphine requirements in the first 24 hours after surgery. So it will help you the complete day not to use opioids for your patient. That's good. That's what we want. But realize that it's not unlimited. The more pain the patient has, the more ketamine you give. But if at a certain point, it will not really reduce more the pain than it's already reducing the pain. Meaning to give more than 30 milligrams per 24 hours on the pump or a single dose or whatever you give, it will not help to give more pain relief. And I didn't know this a few years ago, so we were just giving it on the pump quite a lot. So that's why I finally can say, if there is a pump of ketamine in the ICU used for the patient, it might be on like 5 milligrams per hour. That means that in 24 hours you will give much more than 30 milligrams. But then it's not used for the pain, but it's used for the comfort and the sedation of the patient as well. Because meaning the first 30 milligrams can help you to be pain-free for the first 24 hours. So realize that it's not only used for pain relief, because with pain relief you have enough with this. Right? This one is also in these recommendations by this big group of intelligent people there, thinking about how can we manage postoperative pain, and it's the 18th. And it says, the panel recommends that clinicians consider IV ketamine as a component of multimodal anesthesia in adults. And it says, recommendations, moderate quality evidence. What does that mean? They also understand that maybe for the pain, only the first 30 milligrams is important, but we are giving much more, so it's more not really for the pain, but also for the sleep, multimodal sleep pillar. but we use it. We put our children that we do scoliosis, 13, 40, 50 years old kids, operated for scoliosis, operations, correction. We put them on esketamine on the pump. Do you do that? Exactly the same. And we might give a little bit more than 30 milligram, but we don't care. Good. So from the balanced anesthesia, having 3 pillars, we are going to the multimodal analgesia. Multimodal analgesia. So it becomes a multimodal anesthesia, but in the single pillar of analgesia, it's also become multimodal analgesia. And this multimodal analgesia is used in multimodal anesthesia, is important for postoperative pain relief. If we have a look at that, what is this multimodal medication doing for us? It's mostly suppression of the sympathetic nerve system. We learned that the more we can suppress the sympathetic nerve system, the less pain the patient has. So if we can reduce the sympathetic nerve system, hey, there are other medications that we can use to suppress the sympathetic nerve system. Have we seen that? These medications, yes, can do it. These definitely can do it. Did you hear about this? Do you use this in your patients during anesthesia? Huh? We are starting with it slowly, slowly. It's something that my professor, not the professor of pediatric anesthesia, but the professor overall, is very interested in this. So he starts to give his patients this esmolol. We are already a bit afraid in pediatric anesthesia when we put the mask with sevoflurane, or if there's no sevoflurane, it will be isoflurane. There will be quite quickly bradycardia. And then we give esmolol, and the kid is really having a bradycardia. So we don't want that really, so we are not using it in kids. I talked with him and said, let's think about this, but not really start with it. There must be more investigations, and if you want to have this investigated, we need people to do that. Take the time and all the effort. Not me anymore, I'm too old. But we need to wait and see what will the future bring us about these kind of things. But in adults, it's really used more and more and more to block the sympathetic nerve system. And with doing that, you can use much less opioids in the same operations for these patients. So it is helpful, but it's also still in the beginning phase of the use in anesthesia. Did you hear about this? Comfort Talk. When this started to be an option in my hospital, I said, what are you talking about? Comfort Talk? Comfort Talk. I'm doing Comfort Talk already for 30 years. You think I put the patient on the table saying nothing? This is a kid. Of course I do. Kiddo, kiddo, kiddo. How are you doing? Everything fine? I'm not going to say, I'm going to hurt you now with a needle. Of course I do kiddie talk. And kiddie talk is comfort talk. You distract the patient while someone else is doing the IV. By talking, maybe put some music. Nowadays, everyone has his cinema with him. You put your phone with a nice movie there, kids movie. Distract them while you're going to do something. And I'm not going to tell them, yeah, we are going to stick a needle in you. But yes, in adults, we have to think about comfort talk. Don't tell the patient, I'm going to stick a needle in you. You just say, we are going to give you an IV. That's a bit different than saying, I'm going to pinch you with a needle. And that is all about comfort talk. So in pediatrics, we already do a lot of comfort talk. You start with comfort talk because that's how we talk with kids, don't we? Okay, so there is recommendation 9. Comfort talk. Use it. And use it better and better. There are courses to do good comfort talk. In the Netherlands, they started at my hospital with a good friend of mine, good colleague. And he always said, yeah, look, you do it, but you should do the course because you can learn still a lot. I said, I'd rather go teaching in Bali. Much better for me. But okay, I think it's important to understand what is really comfort talk and how do you do good comfort talk. It definitely can help you to give your patients a more comfortable feeling. And that's what it's all about. So, how are you going to start now? Now we have listened to my lecture already half an hour or more, I don't know. And how are you going to start with opioid-free anesthesia in children? What do you think yourself? Did you already start? I think you already started to give as less as possible opioids. Way before I came to lecture you here. But I just want to let you know and let you realize yourself what is all in that opioid-free anesthesia. And without thinking really about I need to use less opioids, you are already doing a lot of things. And because of doing that, you need less opioids for your kids. And adults, of course. We do now, I think also here, not having an opioid-based anesthesia anymore. The base maybe is not completely regional anesthesia here. So I hear someone saying maybe I come here for a few days doing a workshop. I don't know, we will talk about it. But of course we use acetaminophen, paracetamol and NSAIDs in all your patients. So the base is there. Now try to use more regional anesthesia in your children. Try to think about every operation, what should we or what can we do. Installation of the wound by the surgeon or you postoperatively is also regional anesthesia technique to reduce that pain at that moment in that wound. So regional anesthesia technique doesn't need to be always an epidural, doesn't need to be always an interscalene block or an axillary block or a popliteal block or whatever. Installation of the wound is also a regional anesthesia technique, reducing the pain for your patient at that moment. Think about it. The second, mixture. You are mixturing already. You have already a multimodal analgesia regime here working in your hospital. Comfort talk, okay. In kids, I think you already started with it. Dexmedetomidine as a pre-medication? Neither do we. Because a lot of pediatric surgery is short surgery within the hour, and then the kid is sleeping 1-2 more hours on the recovery. And we don't want that. Definitely not, since we are doing these shorter operations in daycare units. We want them to have them go home as quickly as possible. So dexmedetomidine, we started to work with it, but we also stopped working with it. But it can help you definitely in longer durations of operations. The regional anesthesia, important. And then this one. The mixture of these makes you need less opioids during operations and post-operating. So the mixture of these is something that you should learn to work with, also in children. And the more you use this, as I said, every patient's no, this must be, oh, dexamethasone should stand here. Sorry, wrong word. Actually, every patient should use dexamethasone. I told you it's already a standard medication if in every anesthesia in the Netherlands nowadays. Lidocaine, magnesium, ketamine, we can use it. The more you use it, the more you're going into the real multimodal analgesia, and you will learn that the more comfortable your patient might be postoperatively. And that's where we want to go to. Pain-free postoperative period. And then there is still some clonidine. Clonidine is something we not really use intraoperatively, but if the kid is going to sleep very wild, for sure we give it to let it wake up a bit more comfortable. If it went to sleep normally, but postoperatively in the recovery room, it seems to be very agitated, irritated, looks discomfortable, the first medication we give is a bit of clonidine. And then we don't say completely opioid free, there is the capstone. And the capstone, it is not, I'm not one to tell you you should be completely opioid free, but I'm telling you, I try to teach you that we already are doing as less or as much as possible to give less opioids. But don't forget that there are opioids and sometimes you really need them. Sometimes you have done everything and still the patient is in real pain. Then the patient deserves something to kill the pain. And that something is the capstone. And that something is, it is opioids. So sometimes you need these opioids to make the patient finally pain-free. And our job is to have patients as much as possible pain-free during operations and post-operative. So sometimes you need to use the capstone opioid. Meaning, this has happened, the foundation of anesthesia has changed, we are working in a multimodal practice, opioids are not routinely given anymore, so they cannot be routinely abused postoperatively anymore. But don't forget, as the capstone, you might still need to use it in some of your patients. Thank you. Terima kasih.
Thank you for the insightful presentation. Dr. Luke, maybe you take a short break. Water. Time maybe 5 minutes to make a summary in Indonesian. Oke, selamat siang. Saya akan sedikit mensummary hasil pertemuan tadi. Jadi, Dr. Luke memberikan insight yang sangat cukup menarik untuk kita ya. Artinya gini, yang saya tangkap adalah kita berbicara tentang opioid free anesthesia itu bukan berarti dia bebas opioid. Opioid itu tetap dipakai, tapi arahnya. Dulu anesthesia yang dari single use, jadi dulu menggunakan ether single, jadi multi balancing anesthesia. Balancing anesthesia itu dia membagi 3, sedasi, analgetik, dan juga relaksasi kan gitu. Sekarang karena muncul permasalahan di mana adanya ketergantungan, terutama pada pediatri juga cukup meningkat ketergantungannya gitu. Jadi sekarang mulailah beralih ke multimodel. Jadi multimodel menggunakan beberapa modalitas analgetik yang bisa digunakan seperti tadi yang sudah dibahas, ada ketamin, ada lidocaine, ada dexmethomidine. Tapi kalau dexmethomidine dari Dr. Luke sendiri tadi tidak terlalu menyarankan pada operasi pediatrik karena waktu untuk wake up bangunnya itu cukup lama karena operasi pediatrik biasanya durasinya cukup singkat. Gitu ya. Jadi ada beberapa hal yang mungkin kita bisa terapkan di sini yang sudah kita sering gunakan dari rekomendasi beliau di Netherlands pun menggunakan dexamethasone sebagai rutin penggunaan dalam analgesi, dalam anestesi. Jadi dexa digunakan rutin dan juga penggunaan dari ketamin. Ya, jadi mungkin teman-teman ada yang sering menambahkan ketamin 20 mg per 24 jam, akhirnya terjawab itu berdasarkan hasil systematic review. Ada yang menyatakan bahwa ketamin jika diberikan 30 mg dalam 24 jam lebih dari itu tidak akan memberikan manfaat atau analgetiknya yang cukup. Jadi ketika pasien tidak cukup dengan 30 mg mungkin pada orang dewasa, itu kita tambahkan dosis ketamin tidak akan memberikan efek analgetik lebih baik. Jadi tetap kita akan mempertimbangkan berapa multimodal yang bisa digunakan. Ya, jadi mungkin itu summary dari saya untuk topik ini. Kita akan bersiap untuk ke topik yang kedua. Oke, Dr. Luke, we will start to the second topic about the caudal or dorsal penile block for Hypospadia correction. Maybe this segment will highlight the indication, maybe the comparative benefit or technical consideration and outcome data. So, ready to second topic? Okay, the floor is yours.
Right. This first lecture, you maybe not have really learned something new, but I just hope that you realize that what you do is part of this multimodal things anesthesia has become. So that you are working in a way that you now understand why you actually work in that way. And to give you a thought in your mind, if you didn't use all the steps, to get back to yourself and think to yourself, what are we doing and why didn't we start the first step complete, the second step complete, and then go on? Because from the bottom, if everything is complete, the capstone is not used that much. And then you have your goal achieved. Right? I told you I'm a pediatric anesthesiologist. I like to hobby with local regional anesthesia. So this next topic is a bit more about regional anesthesia. Do you do hypospadias here? Hypospadias corrections? Do you use regional anesthesia for that? Not? Adjuvant? General, she said, no, we don't use regional anesthesia. We use it as an adjuvant. But you use a regional anesthesia technique. If we talk about regional anesthesia, then I never talk about regional anesthesia as a single surgical block. Why not? Because in pediatrics, we never do regional anesthesia as a single block. Do you think you can give a 6-year-old kid a spinal anesthesia and then just leave it on the table like that and say, okay, now we're going to operate your knee or something like that? Cannot in kids. Cannot. We talked about it in the car with Dr. David. I always first put a child under general anesthesia. And if the kid is in general anesthesia, I decide what to use for local anesthesia technique. Meaning, every kid that gets a local regional anesthesia technique is as an adjuvant. It's never a single technique. Remember that. And most of these techniques are for postoperative pain relief. It helps intraoperatively to reduce your opioid use, but it's also directly for postoperative use, pain relief. So that's important to understand. So that's why I said every kid deserves a local regional anesthesia technique, even installation of the wound. And we don't do installation of the wound. Yeah, that one, yeah. I forgot about it. You think, why is he not flipping the slides? Because I've missed this thing. No, this is just in advance because we talked about it. It is, in my opinion, every patient deserves a regional anesthesia technique, but not as the single technique, just in the multimodal analgesia. It's part of your pain management. So we put the kid asleep, sevoflurane on the mask, we do more than 90% of all the kids. First put them asleep with the mask, then give them an IV, then manage the airway, and then we are going to think, that was the first pillar, sleep, and then we're going to think, how are we going to block the pain in this patient? We thought about it in advance, of course, because we discussed it in advance with my resident. What are you going to do? Hypospadia. Okay, I'm going to do hypospadia. The kid goes to sleep with a mask. We put the IV, we put something in the airway, and then I want to do a dorsal penal. No. I want to do a caudal. Who wants to do what? Let's go into this lecture. Who is going to do what? Flip. Sorry. Who wants to do what? Let's see the case report. It's a boy, 11 months old, 10 case, ASA1, no allergy, no previous anesthesia. Scheduled for mid-shaft hypospadia. You understand where it's going to? You understand what the patient is going to get? What kind of operation there? Expected duration 3 hours. What is your anesthesia plan? Think about an anesthesia plan for yourself. Keep it in your head. What should you do? How should it go here in the house? I learned in the car coming up here that most of your kids are going to be having an IV, an awake IV on the ward, and then it comes to you and you give some IV midazolam till a Ramsey score 2, and then it comes into the operation theater and you give a mask with sevoflurane. That's the way you work. So if you have an anesthesia plan, it starts to general anesthesia. It doesn't start with, okay, we first do a block. You can't do that in kids. Yeah. But in adults, do we do local region anesthesia in adults asleep? Or is that not done? It's for a long time in history said, no. The regional anesthesia techniques, like an interscalene block, or an axillary block, or popliteal block, femoral block, we do it in an awake patient. Because the patient can be, and that's very important, they said, our monitor. It can give us information if I put a femoral block and the patient said, ow, ow, ow. I said, okay, then the monitor is going to tell me maybe I'm already intraneural. But then the patient needs to explain me, where do you feel the pain? I feel the pain here, but it also goes to my left toe. Then I realize I might be with my needle point into the nerve. So maybe I have to withdraw it before I go on. Maybe if you inject, you put your needle in and then you start to inject and the patient says, right, oh, well, I feel some numbness and some tingling in my lips. Good monitoring. What do you think a 4-year-old kid can tell you? Oh, stop, it mumbles in my lips. Oh, the pain is in my toe. What do you think of the monitor of a 4-year-old kid? What about even younger? What about even older? Is an 8-year-old kid a good monitor? Even adults are not really good monitors. Even if the patient has pain but can not really describe it. Realize that if you might by accidentally touch with your needle the wall of the artery, it is definitely hurt the patient. And so, what is the pain? Can the patient tell you? There are new articles nowadays in literature that is telling you the ultimate best monitor for doing regional anesthesia is the good use of ultrasound. So with the good use of ultrasound, you can see exactly what you are doing if you use it the right way. And if you exactly can see what you do, you also can see if you are in the nerve or outside. You can see if you're in the vessel or outside. Then you do your injection. You can see if the local anesthetic spreads around the nerve or in the nerve. You can see the spread not coming up in your image, means you might inject into a vascular system. So the ultrasound is giving you the best monitor of what you are doing during proceeding a regional anesthesia technique. In kids, they give a strong recommendation to do it under general anesthesia. The kid is not a good monitor. And on the other side, a kid is not cooperative. Not all the adults are cooperative, but a kid definitely is not cooperative. You talk to this 8-year-old kid, comfort talk of course, and you talk about just sit still, just lay down still here. I will do some alcohol there, and I will do so. It makes it a bit cold. I make it a bit more cold, and then we do give you some local anesthetics that will reduce the pain. Okay, the boy is quiet or the girl is quiet, and then you need to go in. Ooh, what was that? Ow, ow, ow. He's not cooperative anymore. He doesn't want that anymore. Although you have talked already half an hour to him, yes, you stay calm, yes, I stay calm. They are not cooperative. They are cooperative until the moment they are not anymore, and then it's over. So the strong recommendations to do regional anesthesia techniques in children is under general anesthesia. The kid is Ramsey 2, going into our theater. The mask is on. In my hospital, the mask is on. The IV is in. And then LMA or tube. What would you do in this case? 11 months, 10 case, hypospadia correction. Tube. Tube. Why? Children? I think that the 3-hour operation is the most important point. Every kid at my table that is less than 2 hours gets a laryngeal mask. Until it's something intraperitoneal or intrathoracic, or the kid has to lay down on the belly because it's on the back. But otherwise, most of my kids have an LMA. Even the very small ones. Even the prematures. But that was not this lecture about it, so I have to come back for that lecture too, airway management. LMA or tube, in this case, it's a 3 hours operation. And we don't believe the surgeons. They say it's a 3-hour operation. That means I can drink 2 coffees because it's 4 hours. And I'm not allowed to drink 1 coffee each hour, so it's only 2 coffees. 1 coffee each 2 hours. Joke. But for sure, because it's 3 hours, most of my surgeons are operating these kind of hypospadia. There are different kind of hypospadias. So they are different time-consuming operations. Then there is this question. We have the tube inside. We manage the airway. The patient is asleep. Sevoflurane, sleep pillar. We put a little bit of fentanyl, we put a little bit of rocuronium, atracurium to intubate the patient. And then we think about, okay, what are we going to do for pain killing? Giving shots of fentanyl the whole operation? Can. But you also can choose for one of these two. And which one is the best? That's this lecture all about. For this operation. And are we giving it before or after? What would you suggest? Before the surgery or after the surgery? If you decide to do it after the surgery, means that intraoperatively you will need shots of opioids, shots of fentanyl to keep your patient pain-free. I talked about 45 minutes to reduce your opioid use. So why afterwards? Do it in advance. Before the surgery starts, you do your local regional anesthesia technique. Meaning, intraoperatively, you don't need opioids. You can rely on your technique. Right? For this operation. Sometimes not completely, but for this operation it can be complete. What is this here? Both? We do it in advance and we do it postoperatively? Can that? Is that possible? Why not? Why can't we do it both? Because we are using so much local anesthetic? Because maybe the patient gets into toxic doses? What do you think? If it is 3 hours of operations, I definitely do it in advance and postoperatively. And why postoperatively? Because then it will work much longer than all the operation time is already gone. A caudal block or dorsal penile block will last like 5 hours, maybe dorsal penile 6 or 7 hours. But then, if you redo it, so during operations 3 hours, also a lot of local anesthetic is gone and metabolized and excreted. And so on the spongial side, there's not that much anymore left. So you can do the re-injection. You can. And from the start of the end, the post-operative period, you have a new start of your duration of your local regional anesthesia technique. Understand? It is possible. What do you think about epidurals with a catheter? What do you think about femoral with a catheter? Popliteal with a catheter? No, don't do the second dose. No, you put the pump because you want that second dose. You want to have it lasting long time. So you put intermittent dosages or you put a continuous infusion of your local anesthetic. But always in the back of your mind something about this toxic dose. But if you have done the first injection, doesn't mean that after 3 hours you can't put the catheter on the pump, or you can't put the second dose. And for the second dose, remember, it doesn't need to be surgical pain anymore. It's postoperative pain. So if you use a certain amount of milligrams of your local anesthetic, for example ropivacaine, then for the second dose, use the same volume, but half of the dose. So it's half of the first dose plus some saline. Making sure that after 3 hours, you will never really get into toxic problems. Just a sidekick was this, to learn you a bit extra, because I like to talk about local regional anesthesia. Both is definitely possible. It is. And you can use it. Or are there even other options? Do we forgot about something? Let's see. Is this important? It can occur anywhere along the ureteric groove. Is this important for us? Do we need to know that? Yes, we need to know that. Are we becoming urologists? No, but we need to know where this urologist is going to cut the patient, because we need to kill the pain. So we need to know where is the wound going to be happen. Is that important? Yes, it is important, because the dorsal penile block will not work down here. Because dorsal penal is be done at this level more, so the base, not in the sacrum and scrotum, at the base of the penis, in the front side. It's the back side of the penis, yeah, I know, anatomical things. But from here up, a dorsal penis might work. But below, in the direction of the scrotum, a dorsal penal doesn't work. So we definitely need to know where is this incision. And of course, of this reason, I choose mid-shaft. So I choose somewhere here. That means you might already, because of the situation, choose for one or the other. But mid-shaft is from this one, it's like here. So you can still choose one or the other. But remember, if it's lower, don't choose for dorsal penal. It will not serve for all the pain this patient might have. This is about regional anesthesia. The main knowledge you should have if you use regional anesthesia is where is the wound and which nurse do I have to block to get rid of the pain. Important. If you have a tooth problem right in the top, don't let the gigi doctor do his injection left bottom. Huh? No, you want to do it at the place of the wound. That's here the same thing. That's with every regional anesthesia the same thing. Definitely important. Functionality of your anatomical nerve anatomy. If you have a look at these two, then you see that quality and duration of the analgesia is not a significant difference. It will last the same time. It will give a good analgesia if it's done properly. If it's done properly, of course, I did the block, it is done properly. Let's hope so. Also, my blocks are not 100% effective. Sometimes you just did something and it didn't work. Realize that it can happen. Right? This we already saw. So dexamethasone is part of the therapy in these kids. Waiting. IV or local? What do you do? Local with the injection. Oh, we're gonna fight. We are gonna fight. I did that in the beginning too, but I quit. It's something that's not working local. It's something that works more central, right? So since it works central, why do I give it local? Everything you give local, the problem of local anesthetic is that it's not working as all the other medicine. All the other medicine we put first in the central compartment. From that moment we have the top dose, the top concentration in the central compartment, and it only goes down. The local anesthetic is injected somewhere else in the peripheral areas. And when is this top concentration in the central compartment? When is this top concentration there? And is this a toxic concentration or not? Meaning, whatever you put per fill and has to come central to do a central working, why don't you give it central? So, in the beginning, the literature all showed, yeah, you should use dexamethasone because it can prolong your... But then we were looking for different medications. Clonidine is tried, fentanyl is tried, morphine is tried as an adjuvant in your injection. Dexamethasone is tried, dexamethasone is also tried. But here there was definitely evidence for a prolongation of the block. And then people thought, well, why are we giving it actually local? They start to give it IV. Same effect. So in my opinion, I said, why should I mix and then inject? Why don't I do just the local regional anesthesia technique and give the dexamethasone just IV? It makes it much easier. Yeah. Okay. Good. Then, surgical techniques. You better do it between 4 months and 18 months. Is that important to know for us? Yeah, it gives you an idea of what the kid is on your table. Seems to be important for the surgery, for the surgeon, because it's emotionally and physiologically results are better. Quicker wound healing and less risk of complications. If the kid is too young before 4 months, they see that this wound healing is not so good and they see a lot of complications. They see that if the kid is older, they already have a little bit of problem of the fact that it's a bit different there. So they decide it's better to do it in between 4 months and 18 months. For us, just to understand, if the kid is younger and they still want to operate, you might consider with the surgeon and tell him, why are we going to do this small kid for this operation? Why not wait for 4 months? Because even after 4 months, anesthesia is less risk. If we can wait till 10 or 11 months, it's even less risk. But if you can't wait, okay, we give anesthesia, I know, we just have to serve the surgeons. Doesn't mean we can think with them. Risk factors for fistula. Type of hypospadia, surgical technique, size of the penis, age of kid, postoperative edema, swelling of the penis, infection and ischemia. This swelling of the penis has opened up a fight in literature. And we will talk a bit about this fight. First, learn that. How do they see these complications? 46 of these are diagnosed by first check appointment, 6 weeks postoperatively. Then they see, oh, there is a problem here. Remember this, I will show you later again. Then 81% of all the complications by the first year. So this 46 and then the other, like extra 20% is seen within the next of that first year. Average time of diagnosis, 2 months, 6 months for fistula. What happened? They blamed us for all the complications. They blamed anesthesia for the complications. Do you think there is still anesthesia somewhere working after around 6 weeks? So something has already happened during anesthesia. The first 6 hours, that's the duration of your block. And then 6 weeks later or 1 year later, there is an appearance of the complication and it's due to anesthesia. Of course, everything is due to anesthesia. We are to blame. Every surgeon likes to say that. But I don't think it's really the truth. But what do they say? The hypothesis says swelling of the penis after caudal because of an increase of vascularity. Your regional anesthesia is giving vasodilatation. And vasodilatation means swelling of the penis. Right? Increased risk of hematoma and stretching on sutures, thus increased likelihood of complications. But that's not in the 2nd week or the 3rd week. No, that is in the first 6 or 7 hours. Because that is the duration that your block might work and your local anesthetic might be giving vasodilatation and some swelling of the penis. Penile is safer than caudal block because penile is giving less vasodilatation in the last part of the penis. Because there is not the feeding vascularity is not dilated. So it's safer. Penile block gives better analgesia. That's what they say in the literature. And the goal for this study to really try to find the reason there is evaluation of the pineal block versus the caudal block on surgical complications. Compare quality and duration of postoperative analgesia. Compare success and complication rate. This was in 2012. I was busy with doing caudals and all these kids having hypospadias. And then in the literature, they gave this literature and said, oh, caudal is not good. Okay, so what am I going to do? We read this article. 5 times there were patients with fistula of the 54 patients. And 5 times it was with the caudal. But clear difference in size of the penis in caudal group, probably because of vasodilatation, right? Is possible. Definitely possible. But is that the reason for the complication? They said yes, but we don't really know. Penile duration analgesia significantly longer. Penile morphine use significantly less. Is that mean that the pineal block is the only option you should choose? It depends on what the surgeon is going to do. Where is the operation? If it's just at the tip, it's a much shorter duration of surgery. And it's a much faster operation to be finished. It's much more minor surgery than major surgery, and the lower the incision is, it's getting more and more major surgery, and it lasts 3 hours and the whole penis is open. That is strange. They didn't consider these kind of things. So the conclusion was, dorsal penile block provides better and longer analgesia than caudal blocks, all fistula in the caudal group. Meaning, the surgeons give a recommendation for a dorsal penile block. Do we agree? Do we agree? We miss things here, don't we? Yes, we definitely miss here. What is the classification of hypospadia? The difficulties during surgical procedure, the age of the kid and size of the penis. It's not taken into the considerations. Then the fight starts. Okay, we need to fight. What are we really doing? What are you doing? First publication started to be there, 2015. It's telling us in this series, we found association between the use of caudal regional anesthesia and fistula formation. Oh, association. Okay, I read too fast. No association. So they say you can use caudals, but location of the starting uterus meatus, prolonged surgery, subcutaneous epinephrine. We are anesthesia, we don't use that subcutaneously. This is surgical things, right? Are associated with fistula forming. This is surgical things, not the anesthesia. Okay. Can regional anesthesia have an effect on surgical outcome in patients undergoing distal hypospadia surgery? See the article, 2017, Pediatric Urology. Not pediatric anesthesia, but pediatric urology. What do they say? Anesthesia complications. Pineal block, less complications. Caudal block, whoosh! Lots of complications. What do they say? The conclusion, the main goal of the study was accomplished by demonstrating that in our series caudal anesthesia is associated with a higher risk of fistula. Is there said something about the fact that it was a lower, more major surgery than just the top? Is it said something about the age of the patients? Is it said something about the use of epinephrine subcutaneously in the penis? Nothing. 2017, Journal of Urology. Cause of effect versus confoundings. Is there a true association between caudal block and the tubularized inside plate repair complications? My God, I'm happy I'm not a urologist. What do they say? Our data indicates that the hypospadia severity and not the type of regional anesthesia was the only risk factor significantly associated with postoperative complications. So this group is bouncing back to their own group. It's our surgery and the problems in our surgery and the way we have to operate this patient with a major operation. Yeah, it's just a penis, but it's still a major operation if it lasts 3 to 4 hours. And not anesthesia. 2017. Then they said again, let's go to anesthesia. What is anesthesia saying by itself? Conclusion, in our experience, caudal anesthesia was associated with an over 13-fold increase in the odds of developing postoperative surgical complications even after adjusting for uteral meatus location. Meaning even if it was just up. What is this? A 13-fold more risk? Do we believe this? Wow. There was a lot of comment about this article. And these articles are just written all around the same year because just people want to publicate and then they publicate this. But what is really true? Until further investigation occurs, clinicals should carefully consider the use of caudal anesthesia for children undergoing hypospadia repair. Meaning anesthesiologists are telling other anesthesiologists, don't use caudals anymore. We were using them for 20, 30 years. And now they say themselves, we should not use it anymore. Is this a good investigation that can tell us really not to use it anymore? The comments in an editorial, same year. Conclusion says, were this to be true, it would argue for significant changes in practice for many pediatric anesthesiologists. Over the whole world, we are doing caudals for hypospadia correction. Should we change? Were this the truth? If such an enormous measured treatment effect were accurate, one would not expect there to be other investigations that can found no effect. If it's so evident that you will have problems when you do a caudal, then why can other people find no problems with the caudal? Very wide confidence interval must give greater considerations to the imprecision of the results despite the small p-value. What did they do? It suggests a lack of stability in the data and may limit the ability to draw meaningful conclusions. How could this article end up in the literature? Was there not a proper reviewing someone that says, whoa, your investigation might be not really good? You might did some wrong things with the mathematics to come to your worldwide considering conclusions not to do caudals anymore? I was very happy to read this, that there was at least someone taking care of the conclusions. The transient increase in blood flow that might result from vasodilatation due to the caudal block has not shown under other circumstances to result in wound or anastomotic descensions. So, the investigators are unable to quantify several critical factors such as the duration of the pineal tourniquet or the use of epinephrine for hemostasis. So they also missed a lot of things. They make errors with the mathematics and they missed a lot of things. But is something that is affecting your daily practice. Happily, a lot of my colleagues do not really read the literature. They should do, I always tell them. But okay, they just kept on doing the practice and said, look, what are you talking about? What a fight in the literature about well or no, yeah, yes or no for a caudal. We just do a caudal. Just go home. We do a caudal, don't worry. I said, well, in literature, they are very worried. In literature, they are learning us not to do it. You just do it. Happily, they just do it. 2021. Pediatric Urology, the Journal of Urology, they said together, our data suggests that meatic location, older age, extreme prematurity and surgical durations are associated with increased incidence of complications following hypospadia correction. Analgesic block has no association with increased hypospadia complication risks. End of the conclusion. End of the fight. They ended themselves. What did they say? Urology 2022. The type of analgesia block is not associated with the risk of developing complications following primary hypospadia correction. Meaning, we finally can choose by ourselves what to do, yes or no. Although we will fight against some anesthesiologists that fight against us. But we can still choose. So what to choose? Definitely the site or the position of the wound is very important. So, caudal or dorsal and spinal. The classification of the hypospadia. Where is it? Do we do before or after? There's still other options. Is there another option? Huh? Both. Can do both. But did you hear about this? Pudendal nerve block. Pudendal nerve block is even a bit more central than the dorsal penile block. But it's a peripheral block instead of a central block like a caudal block. It can be used for lower incisions than mid-shaft surgery. So this is definitely an option. But it is definitely block done with ultrasound. Dorsal penile, still a lot of my colleagues, they know that I have the ultrasound in my backpack with me. No, not really. But I always do everything with ultrasound. And they still do sometimes like the caudal or the dorsal penile just blind. It's done within a minute by use ultrasound. The effectiveness of the block is very high. The success rate of the block is very high. So why should you use ultrasound to make sure that your position is right? I add a little bit to the lecture. I come to that. Sometimes caudal is a bit difficult. So how can we get a good caudal block even if it's difficult? But pudendal block is something. So it becomes more like this. We choose one of these local regional anesthesia techniques. And yes, if the caudal might be difficult, I think, another fight here in the front, you should not change to dorsal penile because of the caudal is difficult. You cannot if the incision is low. And if the incision is low, the dorsal penile block doesn't be effective. So you need to do the caudal block. Then you need to learn how to do a difficult caudal block. And that part I just added at the back of this little talk. So, conclusion. Local regional anesthesia techniques are an important part of our daily pediatric practice. Every patient deserves a local regional technique as an adjuvant, not as surgical option, not as a surgical block like a spinal can be for an adult to operate the knee. But we are not going to do that in kids awake under the local regional anesthesia. We do it in general anesthesia within the pain pillar, in the base of the pain pillar, paracetamol, diclofenac, and one of these blocks. Depending on Where is the incision? So, with the right knowledge and experience, local regional anesthesia is very effective to kill the pain for your patient. It's safe as long as you do it the right technique with the right equipment, and the right equipment is use your ultrasound. You have ultrasound, right? You have ultrasound. You use it for all the blocks? Very good. Very good. I still have some colleagues that don't like it. I started 21 years ago to do local regional anesthesia with ultrasound. Can you imagine? Can you imagine? I was the first to do it in the world in a kid. Me? Yeah. It's still, 20 years is still young in anesthesia in the medical world. Something that exists 20 years is still young. We rely on a lot of knowledge that we know from over ages. Years and years ago. And now ultrasound just started about 21, 22 years ago. And it becomes daily practice. And I'm very happy with it because it's important to know what we do and to give an effective block and also in a safe technique. So, it's effective and safe, although pediatric anesthesia is never safe. It's challenging, not because the kid is challenging, but everything makes it challenging. Questions so far? Now we do the questions later, right? So, okay. Just before the lectures were loaded, or actually the lectures were already loaded, there was a question about, okay, what do you do if the caudal is difficult? So I thought, the caudal is difficult? No, the caudal is never difficult. Yes, the caudal can be sometimes palpated wrongly, it's difficult. So how do you do a caudal? Do you do a caudal with ultrasound? Huh? Why don't you use it for the caudal? More faster. But what if you can't feel it correctly? What if you can't feel it correctly and then you said, okay, then I shift to dorsal penile. But what if dorsal penile cannot for this type of surgery the surgeon is going to do? You have to choose for a caudal. But then the caudal is difficult. How can I manage? I never do a caudal blind. If you learn it to do ultrasound guided, yes, of course, the first time you do these block ultrasound guided, it will take you time. There is no surgeon anymore in my hospital that is telling me, look, come on, hurry up because we need to go. You with your local techniques. They understand that after years and years of practicing more and more local anesthetic techniques, after my group of pediatrics anesthesiologists in my hospital who are doing almost in every kid a block, they realize this is really helpful for the patient. So they let us take the time to do the block. And after doing it 2, 3, 4 times, it will be as fast as blind technique. Because if the blind technique, you can't feel it, you are feeling longer than putting the probe on, oh, I have to go there. You understand what I mean? I try to teach you a little bit about how do you do ultrasound and caudal blocks. It's out of another presentation. It's not made as a presentation in total, but I just took it out and put it below this one. Is ultrasound useful in caudal blocks? It was a preliminary study, 2005, by Roberts. He is a well-known pediatric anesthesiologist. He wrote part of the book of the Nysora. The other name there is someone called Luke Thielens. I don't know if that's important or not, but okay. He said, you see, it is important because the good needle position is essential for a successful block. If you can show with your ultrasound that your needle is in the right position, you will have an effective block. And yes, I know that the efficiency of a caudal block is about to be 97% of all the blocks will be functioning. But what about these 3%? Some people say, no, caudal block always works, so the efficiency is 100%. Why should I do it ultrasound? Because they lie, because there are still a few percent the block is not working because your needle position wasn't the right position. But ultrasound can show you the right position of your needle. And it is your needle position in every local region anesthesia technique that will be the most important fact if you will have an effective block or not. If you want to do an interscalene and you are in the mid-scalenian muscle injecting all the local anesthetic, your block might not functioning that well. So it is the needle position very, very essential to have an effective block. Your needle position for caudal must be in the caudal epidural space. If it's in the bone or below the bone or subcutaneously, the block will not work. And complication control. You can see if your needle is in the spinal fluid through the dura. Yes or no? Yeah, but I always aspirate. But you should aspirate and hold it 2 seconds. Because these needles that we use are so tiny that if you aspirate for liquor, cerebrospinal fluid, which is like fluid, like water, it might come through your needle. But definitely if you are in a vascular system, the blood needs time to come through that needle. So if you just do aspirate and loose, nothing comes there, it's not enough. In kids, you should aspirate and hold it. Hold it for 2 seconds. Give the blood the possibility to come through the whole length of your needle. That's the truth. Otherwise, you might mistakenly inject intravascular structures. I'm not so afraid for the cerebrospinal fluid, but for vascular injections. You can do a test dose with some saline to see the reliability of your needle position. They did that 2005. Nowadays, as I told you, the best monitor is your ultrasound itself. If you see your needle position within the normal anatomy, in a situation you really want it to be, it will be there. So the control, the monitoring of having the needle in the essential, important right position can be seen with ultrasound. And not touching from the outside and do it blindly. Good. And the complication control. The blood, I told about it already. Sometimes cerebrospinal fluid, you don't want that. It can easily identify your target. Also, when palpation might be not that easy. And that's the case here. When palpation is like in this baby, not that easy, chubby, what do I feel? Can I actually feel something? Well, I'm not sure. Can I feel in this dimple something there? Or is maybe difficult to feel here? Then it's definitely needed to use your ultrasound. Because with the ultrasound we can look inside and see the anatomy inside which is involved. How to do ultrasound guided caudal blocks? You start with the technique having a transverse position. The kid is slightly laying on the right side, having an LMA in. laying on the right side just for 3-4 minutes to do the caudal block. Knees are bended to the nose. The nose is bended to the knees. So you have a round back of the child. You put your probe, transverse position. This is the ass. Transverse position. And you see something like this. Like two frog eyes. Two frog eyes. And something in the depth. Looks a little bit like a frog. What are the eyes? The eyes are the corneas. Sacral corneas. And between the sacral corneas there is a membrane. And when you feel the sacral corneas, yes, you can do a blind technique. But if you can't feel him, you definitely always can see them. But if you can't feel them and you just put your needle somewhere, I understand you don't choose for caudal. But if you put the probe and you see the frog eyes, you know that in between this tiny layer here and this tiny layer there, this is sacrococcygeal membrane going from one cornea to the other. This is the ventral part of the sacrum. So in between the ventral part and the posterior corneas there is a blackness, grayness. In the real slide on the computer it looks a bit more grey, but here always with the making it on the slides it's getting blacker. You lose contrast there. This blackness is epidural space. Meaning if I put my transducer slowly downwards, what's going to happen with my caudal space? It will close. So it will go narrow, 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 and then it's gone. And I only see bone. Coccygeus. Think about the anatomy. Then, if I go from coccygeus up, 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 this will open up more, more, more. If I go higher and higher, I will see dural sac. If I go higher and higher, I might even see myelin. Myelin. I might see there cauda equina in the cerebrospinal fluid. The blackness of the fluid with the white line around it as the dura mater. The younger the kid, all these things you can see. But where you're looking for to do the caudal is just two frog eyes and a smile, cornea, cornea, anterior part of the sacrum, and this little layer, sacrum-coccygeal membrane. Your needle has to go through this membrane into the epidural space. That's it. But we're not going to do it this way because this way is out of plane. I should put my needle in here and come into this image. I can't put my needle from there into it because the bone goes around here. You don't see it because there's shadow underneath the first layer of the bone. But I never do it this way out of plane, so I change my position and I change it in the longitudinal position of the probe. So my probe now looks from down here upwards, and I draw already on the skin one of the corneas and two of the corneas. You see the image is much better here. Much better here. This little black layer, sacrococcygeal membrane. This grayness, epidural space. Good technician here. Can you go back to the normal size? Back to the complete slide. There. So this should be the position of the probe, linear probe, with the needle coming from caudal upwards. So the image will be, come back, go to the next slide. There. This should be your image in the longitudinal way. What do we see on the image? The first thing you see, if you do an image like this, try to find this ventral part, these ventral parts of the os sacrum. Very white lines with a blackness underneath, the shadow underneath. Then you have your ventral part of the os sacrum, meaning on top of that will be epidural space. Meaning on top of that, there will be some part of the dorsal part of your sacrum. And in between the sacrum is, how do you call that? Having a space inside? How do you call that? In Dutch we said it's hole. What is hole? Like a straw. Has an opening inside. How do you call that in English? I forgot. Stupid. English is not my mother then. Belanda. But okay, it is open area. In between, like a straw, like a tube. So like a tube, it's open there. That's your epidural space. It's open in the tube. So the dorsal part of the tube is the dorsal part of os sacrum. Ventral part of the tube is also os sacrum, but at the ventral part. This is the first you might see in your image. Then you realize, okay, there will be a dorsal part. And then from the dorsal part, there will be a superficial fascia, superficial bone, periost. There will be a superficial periost and there will be a deeper periost. And the periost becomes here connected to the periost of the coccygeus. And it's these two layers of periost that is becoming the sacrococcygeal membrane. So your needle has to come from this side here, dorsal side, going against the sacrococcygeal membrane and then into the area where it's gray. And if you look from the grayness up, you might see here the start of the caudal sac. You don't need to look for the caudal sac. You need to find this double layer. One layer, two layers. This double layer is your sacrococcygeal membrane. And even if the baby is chubby, you might put it on a bit deeper than 1 centimeter to find it, but you can find it. You will see it. It's not 5 centimeters deep, it's maybe just 1.5. But 1.5 centimeters of chubby feel the cornea might be difficult. See them with ultrasound? Same. Let's see how it is in a movie. Can we put this on? Cornea. The blackness is the sacrococcygeal membrane. There is the anterior. There is my anterior layer. There's my posterior layer. There is my ligament. So this is epidural space. My needle comes in from this side, hits the sacrococcygeal membrane, enters the epidural space through the sacrococcygeal membrane, and you poop it like that. Don't go further in than the first spine on top of this os sacrum, because the caudal sac might be already there in these small kids, because the anatomy is a bit different. Then you start the injection and then you look upwards. I'm trying to find the caudal sac, which is here. Is it the end? Okay. If you start the injection, you can see here moving local anesthetic, pushing the caudal sac downwards. And the more local anesthetic goes upwards in a blackness, the more it pushes down the caudal sac, and you see the dura mater as a wave pushed down. Try to find it on internet. I just fit it in, so I can't show it you now. But this is happening in a caudal block. Yeah? Want to see it again? See it again? Can. It's here now. So, we first have a transverse position. We try to find the corneas. You move a bit around. Oh, you see a white layer. Oh, the white layer. Oh, there are the foci. Very small. I go from dorsal to more cephalic. The opening of your epidural space. Sacrococcygeal ligament. We turn and there is the ligament. There's the epidural space. We were looking here, coming from very narrow, very wide. Then your needle comes in, you can exactly see what you're doing. Chubby or not. having a dimple or not. You can feel it very well. But if you use this, you can see what you do. And your caudal is going to be effective, although you had problems to feel it. Right? Conclusion here, this study showed that the current landmark for infant caudal anesthesia is unreliable. Importantly, the sacral hiatus is clinically identifying only if the sacral cornea are palpable. If they are not palpable, what do you use? You need your ultrasound. Despite the limitation in central neuraxial anesthesia, we recommend the use of ultrasound since it reduces the complications and increases the success rate of first puncture in pedial caudal injection. So use your ultrasound. And this is the way to use it. Terima kasih.
Thank you for your excellent presentation, Mr. Lu. Okay, before we do the Q&A question, maybe a summary. Indonesia, oke. Seperti sebelumnya, mungkin saya akan melakukan summary dalam bahasa Indonesia. Jadi untuk pemilihan regional khususnya pada Hypospadi, tadi kita sudah belajar bahwa pemilihan lokasi dari Hypospadi, di mana dia di mid shaft, kalau dia di atas lebih ke proksimal, dari mid shaftnya itu lubang di proksimal, kita masih bisa memilih penile block. Sedangkan kalau di lebih bawah, kita bisa memilih penggunaan caudal. Karena kenapa dibagi? Mungkin karena dari dulu itu diributkan. Artinya nyatakan bahwa banyak komplikasi terjadi pada caudal yang terdapat pada post-op, tetapi yang terbaru tidak ada pengaruhnya antara caudal terhadap komplikasi yang terjadi. Jadi sebenarnya caudal bisa digunakan. Untuk pemilihan pada kasus-kasus sulit mungkin kayak pasiennya obes, dia ada dimple gitu, kita bisa menggunakan ultrasound. Jadi sebenarnya caudalnya sangat useful kita gunakan pada operasi-operasi pediatrik. Dan seperti dokter Luke tadi sampaikan, regional anestesi bukan merupakan pilihan utama dalam anestesia, tapi sebagai ajuvan dalam analgesia pada pasien pediatrik. Jadi tetap kita memilih menggunakan general anestesi pada pasien pediatrik. Jadi untuk supaya pasien kooperatif dan juga merasa nyaman. Okay, we will start the third session. In Q&A session, maybe our participant have a question. Can you raise your hand? Or Dr. Putu, there is.
Test this. Thank you, Dr. Luke, for nice presentation. We have recently research for the Hypospadia and rhinoplasty last year until February 5. Collected the 6 patients. Half general anesthesia and half general anesthesia combined with caudal continuous with ropipacaine. The outcome is pro-inflammatory response like interleukin 1 beta and interleukin 6, and outcome pain, plaque score, and early enteral feeding and length of stay, hospital stay. We concluded that the pro-inflammatory response in control group with caudal continuous is much better than the general anesthesia alone. And early feeding and but length of stay is the same because our pathologist pediatric has make a SOP like a standard patient procedure that must be 3 or 5 days in hospital with So the I agree with you, but swelling makes the cell caudal is much better for the especially Hypospadia plastic. And actually, our urologists feel same like the in the surgeon. Maybe 15 years ago, like us, young anesthetist, they push our work quite. So 10 years ago until now, they feel the caudal anesthesia is much better for the patient.
Congratulations with your study. It's a nice study. It's nice to hear that you did this study and that you do use the caudal catheter, right? It's good to hear the results, that it is positive for the use of caudal catheters. It's good to hear your surgeons now believe you, that you really are doing this not to bully them, that you do this for patient care. And they understand more and more the patient care because they see the patients with the caudal catheter are doing much better on the ward. So they start to understand what we do is really patient care and not just to bully them during operation time. That is the truth, and that's fine to hear. Always good. One little thing for me is that you should really control caudal catheters because of the infection rate is higher in caudal catheters than other epidural catheters. Caudal catheter is an epidural catheter, only the point of insertion is very low and close into where there is the phages and things like that. So you really should have a good plastering and covering up the entrance because it's infection risk, and that's something you can. Yeah, you have to train your ward nurses to really have a good look at that. Every time they change the diaper, it's important. Yeah, well, yeah, this can be due to still a kind of lack of information into the public to come earlier to the hospitals, and that will take a lot of time for people to change that. If there is something, just go to the hospital. And now in my country, they are coming even too early. The baby is born, this penis is not correct. The second day, they are already by the urologist. Oh, this has to be made properly because it's not good. And that is due to years of sending information to the public that if there is something, we have a public health system, so come to us because it's needed. But here it's not needed within the first 4 months. But then the parents already have the information. Okay, we come back by 4 or 5 months, and then they come back. Yeah. But this is maybe a lack in your country about the knowledge within the whole population. It will grow, I think.
I read in urologist report that the complication of fistula is still high in hospital in Indonesia. Recently in 2020, they report still 12% for the fistula. So the pediatric urologists make the change to conservative, maybe the whole fashion surgery to make a deep like rise in size it's much better outcome than before.
With the older age.
Yes.
Yeah. This is something that is taken into the consideration in my country more and more. That's on the slide that says, okay, it gives you a kind of psychological trauma. But in your country, if there is more infection or more dehiscentia or more fistula forming, there is a kind of risk for it. So if that is less with some more age, then you say, okay, maybe it's a bit like a psychological trauma for the kid, but it's better to have no complications when operated instead of having some kind of psychological problem with the fact the penis wasn't right. You understand what I mean? It's more secure not having complications after surgery than this part of the psychological problem. Yep.
And my question is, in your country, the surgeon for doing Hypospadia abdominoplasty is what kind of urology surgery only, or pediatric general surgery, or plastic surgery? Because the three of them.
No, in my country, only urologists, pediatric urologists, not to, we have definitely a change. Pediatric urologists are operating this problem. No general surgery, pediatric surgery, no pediatric plastic surgery. This is something for the urologist. I can, and the 36 patients you have in your study, is there noted who did the operation? Can be very confrontating. Okay, but you should have it. If you do it by yourself when no one knows, because you might find something that your colleague, the surgeon, doesn't really like. But that is something, yeah. The discussion in my country is always like, how can we make the quality and the safety of what we do to our patients as high as possible? Meaning, if 3 different surgeons are operating the same thing, there is an expertise on 3 different levels. While if you put it in one, they grow with the expertise much faster because they are operating more kids. And now this, like, everyone has a little bit of experience instead of one group has a major experience. So we concentrate and our care. If you look at in my country, we had, I talked about it, the 5 different centers of cardiac pediatric surgery. My hospital was one of it. I did that 25 years ago. But we changed. We make 3 centers to make the expertise in every center higher than in 5 different centers. And that means we lost the battle. Keep it in our hospital. We got different things back, but that is it. In my hospital, we do ROPs, which is retinoplasty things. Kids, neonates who have an oxygen therapy for a longer time, they make neovascularization in the retina. If you don't stop that, they become blind. So you have to stop that. You do that with a laser technique. We are the only center in the whole country. So if there is a neonate in another part of the country and needs this operation, it comes to my hospital with the ambulance. We do the operation, and the next day it goes back to their hospital because we have the expertise. They can do 3 operations here, 5 there, but we are doing every week. So that's how it works for our country. And I think this is something like that. Why do you have 3 specialists operating the same thing? Is this really plastic surgery? I don't really think so. Is this pediatric surgery? I don't really think so. I think this really belongs to the pediatric urologist. See what I mean? But it's also a long way to deal with these kind of things in your country.
Okay, thank you, Dr. Luke. I have one question. Maybe you can depend on your experience. what the kind or types the needles you use in caudal anesthesia, because in our country maybe we use IV catheter, maybe we use Abocat, or yeah, we use the epidural, or I look in the image that spinal needle you use in your image. What you prefer in your experience?
We use the Epican needles, and the Epican needles has a membrane, and everything you are pushing into the epidural space or into the spinal space is something that we use like a membrane inside. So if you don't have a membrane inside, you might push little particles of skin tissue, like a few cells, might enter the epidural space and have there a growing effect in that, and then you have a real problem. So that's the reason why you go and use membrane needles when you go to epidural spaces. I understand that not every country has it. I was in Tanzania 3 weeks ago. They were using IV needles, but at least they did caudal blocks. Good for the patient, but not completely the material you should use. Yeah, but then, okay, there is no Epican needle there. And I can bring like one box, but then 2 weeks later it's finished again. So you know what I mean? So it's like, yeah, what do you have and what can you use? Realize some risks that you take if you don't have these membranes in the needle, to make sure that your needle is not pushing in some skin tissue, skin cells in the epidural space. That's the most important thing. And if you don't have anything else, yeah, you use what you have.
Thank you, Dr. Lux. There is another question. Okay, Dr. Welly.
Good afternoon. Thank you for the opportunity, sir. My name is Dr. Julian from the Anesthesiology Department, resident. I'd like to ask you about the opiate-free technique of anesthesia. My question is it possible to use opiate-free technique in a very long duration of surgery? And if it is, from your point of view, what arguments be best for us to do so? Thank you.
One thing, if I want to really be opioid free, then you should use your multi-modal medication in the proper way. But I think that every long duration of operation is also kind of an operation that might give a lot of pain relief in the patient. So during anesthesia, during the operations, you might still need to use your opioids. I told you that there is no need to be completely opioid free, but at least try to make it the way that you might use opioids intraoperatively, but in the total regime you have taken into your considerations to be as good as possible pain-free postoperatively. And to be good pain-free postoperatively means that you don't need to prescribe opioids in that period. It's the opioids used in the postoperative time that can give the patient this nice feeling why he wants to use it again and again and again. And the abuse might start. So if you have a long operation, yes, we use mostly just opioids during the operation if there is not a complete covering everything local region anesthesia technique. For these operations, even if they are 4 hours or 5 hours, because some surgeons, they say it's 3 hours, but it becomes 5, you can have done your caudal block and then you hope after 3-4 hours, okay, I hope the caudal will still function till the end. And sometimes, yeah, then it's 5 hours already, but you could cover it with just one region anesthesia technique. If it's for a scoliosis correction, you don't have local region anesthesia technique to cover the pain. In the end, we will do 2 epidurals placed by the surgeon, but you can't use them during the operation. So the whole operation will be done under opioids to block the pain of that patient. So you have to use opioids. So it's not a question of how can I do 5 or 6 hours operations without the opioids. Maybe you should use them. But on the second hand, you should think about how can I block the pain as long as possible post-operatively. And that means end of the operation, you stop your opioid use and you have loaded the patient with a multimodal treatment of magnesium, lidocaine, esketamine, which maybe you might continue the esketamine for the first day on the infusion pump, low dose, and so keep your patient pain-free post-operatively without any opioids. So I can't really suggest you what to do, but this is how we mostly do it. And nowadays we use methadone. Do you use that? For the scoliosis we start to use methadone, very long acting opioid. It definitely works the second day post-operatively still. But these patients are really still in pain. If they start to move, they are really in pain. So they really need something the first 2 days post-operatively. And not only the epidural catheters. So it's not that I tell you never use opioids again, but use it in a way that you remember that the problems will start post-operatively. In that period, you try to be with as less as possible opioid use. That's it.
Thank you for the answer.
Another comment from Dr. Eli? Okay.
Sudah terjawab, Dok.
Okay.
I cannot give you a complete schedule for what do we do in esketamine because that is patient reliable. We use esketamine like we give a bolus of 5 milligrams and then put the pump on 5 milligrams per hour. That means 1 ml and then 1 ml per hour. We use lidocaine sometimes in single dose, sometimes in the pump function. So I cannot give you a complete schedule for that, what to do, how many magnesium. It's all written somewhere in literature, but also if you go to these how do you call it? These apps about pediatric anesthesia, you can see what you can give or not can give. But it's also something you should write for yourself down every operation. What am I going to use in this kit? In adults is more standard, because adults have kind of standard body weight. But kids from 0 to 16 years old have a complete different body weight. And so it's always relying on what do I have? How is my patient this moment on this table with me? Is it 5 years? Is it 1 year? Is it 6 years? Is it half a year? It's completely different. So you should write down what am I going to use in this case, with this patient, with this operation, and this problem.
Okay, this is interesting. Maybe I will translate in Indonesia. Dr. Lu menyatakan bahwa tetap konsepnya OVA pada pediatrik adalah menggunakan opioid serendah mungkin atau sedikit mungkin. Tapi tetap pada piramida tadi di topnya itu selalu ada opioid. Cuma Dr. Luke hanya bisa menyebutkan apa aja yang bisa digunakan mengkombinasi dexa, dexmedetomidine, clonidine dan sebagainya, esketamin. Tapi beliau menyatakan bahwa beliau tidak akan bisa menyarankan apa regimen yang digunakan karena setiap pediatrik itu memiliki problemnya masing-masing, beda sama dewasa yang bisa di-standardize. Karena pediatrik kan risknya luas dari neonatus, infant, adolescence itu beda semua. Jadi memang medicine is art gitu. Jadi yang penting kita tahu jenisnya itu yang bisa kita gunakan untuk mengurangi opioid, tetapi bagaimana urutan cara penggunaan itu depend dari kita masing-masing. Karena setiap sumber itu berbeda-beda. Mau ada yang digunakan single bolus, mau di drip itu bisa-bisa saja. Tapi ingat kondisi pediatrik tidak bisa disamakan. Jadi tidak ada rekomendasi apa yang bisa diberikan, tapi jenis-jenis obat sudah disampaikan. Oke.
You can make a file for yourself or for the hospital. I can show you about, for example, the scoliosis operations. There we use a lot of different medications, and all the medication is depending the weight. But this file is made that if you change the weight from 20 kilos to 40 kilos, it gives you what to give for 40 kilos. If you change it back to 5 kilos, it gives you the medication what you use for 5 kilos. If you change it to 18, you know what I mean? It's something I can show you how it works, and then you see that you can calculate it all the time, but you also can fill it in a file, and then you get all the numbers that you should give in that patient. Considering that the patient for the rest of the thing is all normal without any coexisting diseases.
Okay. Release. Okay. Right. Another question? Thank you, Dr. Luke. If there is no question, maybe it's all clear. If there is no question, maybe my time is up. I will take back the times to Dr. Sherlyn. Thank you, Dr. Putu, Dr. Luke. Thank you, Dr. Sherlyn.
Wow, such a thought-provoking and insightful presentations. Thank you, Dr. Luke, for sharing your expertise with us today. As we come to the end of this enlightening guest lecture, I would like to express my heartfelt gratitude to all of our moderators, our sponsors, and attendees for making event such a success. I hope you have found this lecture both informative and inspiring, and that you leave today with new perspectives to enhance your practice. Thank you once again, and allow me to close today's event with Paramasanti. Om Santi 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 Om.
One, two, three.